Hello, my name is Giobel Rounds, and today we are going to be talking about some crisis management scenarios. And we're going to be going through all the crisis interventions that we are supposed to take into considerations when dealing with patients. The first scenario is I'm seeing a 45-year-old male patient with a history of major depressive disorder treated with citalopram 20 milligrams daily. He presents in acute emotional distress after discovering that his wife has been cheating on him for 2 years and have left him with their children. He reports suicidal ideations with a specific plan involving a firearm and has been drinking alcohol nightly. With this patient, my first step is to perform a thorough suicide risk assessment. Because the patient has already endorsed suicidal ideations and a plan, key elements I will assess include intent. Does he intend to act on the plan? He already reports that he has a plan involving a firearm. I will assess his means, determine whether he currently has access to the gun, and specify the time frame, how soon he intends to act. Does he have any previous attempts? I will also explore protective factors like his children's. I will explore in any history of substance abuse. Apart from alcohol, he already states that he used, and I will find out about some support system. This patient has multiple high-risk indicators, including active suicidal ideations, a specific lethal plan, access to a firearm, worsening depression, alcohol use, and acute psychosocial stresses. These factors indicate high suicide risk and require safety interventions and further evaluation. Based on this information, the patient will be categorized as high acute suicide risk. Clinical factors supporting this include a specific suicide plan, access to lethal means, significant life stressor, alcohol misuse, functional decline, hopelessness. High risk requires immediate intervention and higher level of care. We should probably consider urgent psychiatric evaluation, possible hospitalization, and safety plan. My next step is ensuring the patient's immediate safety. I will ask directly if he currently has access to the firearm. Encourage him to voluntarily relinquish the firearm to a trusted person or law enforcement. I will avoid leaving the patient alone. Because he has active suicidal ideations with a plan, outpatient management alone will not be appropriate. Higher level of care and immediate safety measurements are required for this patient. This patient requires immediate psychiatric hospitalizations or crisis stabilization. Steps include inform the patient that due to safety concerns, I recommend inpatient hospitalization. Arrange emergency psychiatric evaluation. If the patient agrees, start a voluntary admission. If he refuses, initiate involuntary hospitalization procedures based on danger to self. These follow the law that says duty to protect patient safety. The patient reports drinking at least a 6-pack of alcohol nightly. Alcohol significantly increases suicide risk and worsens depressive symptoms. During hospitalization or crisis stabilization, he should receive substance use assessment, possible detox monitoring, referral for dual diagnosis treatment. The goal here is to stabilize the mood, reduce suicide risk, and initiate treatment for co-occurrent substance use. Once the patient is stabilized, medication management should be reassessed. Considerations may include evaluating effectiveness of current medication. In this case, we're going to evaluate if the Citalopram dose is adequately managing the present symptoms. We also going to look into possible dose adjustments or augmentation. We're going to monitor for worsening depressions. We need to keep in mind that the priority in this clinical scenario is safety and stabilization. Medication management is not the first priority during acute crisis. Safety is. For this reason, medication adjustments should only occur after suicide risk is addressed. In the longer term, treatment should include crisis counseling, cognitive behavioral therapy for depression, grief and loss counseling, substance use counseling, and family therapy if appropriate. Once stabilized, the patient should participate in collaborative safety planning, which includes warning signs. Identify thoughts, emotions, or behaviors that signals increasing distress or suicidal risk. It should include coping strategies. We should develop healthy coping techniques the patient can use independently during moments of distress. Identify emergency contacts, trusted family members, friends, or support persons that the patient can reach out for help. We're going to encourage the removal of any lethal means. Ensure that the firearm, medications, or other lethal means are safely removed or secured. And finally, we're going to provide a crisis resource such as the 90-day suicide crisis lifeline. The goal is enhance patient safety, strengthening coping skills, and reduce the risk of future suicidal behavior. In summary, this patient is experiencing a severe emotional crisis with active suicidal ideations and a specific plan, placing him at high suicide risk. The appropriate intervention is immediate safety assessment, removal of lethal means, and emergency psychiatric hospitalization, followed by comprehensive treatment for depression and alcohol misuse. Now we're going to move into the second scenario. In this case, I am evaluating a 19-year-old woman, 2 months postpartum, who presents with rapid speech, tangential thought process, grandiose and bizarre delusions involving aliens and her infant. Her husband reports behavioral changes over the past 2 weeks and fears leaving her alone with the baby. This presentation raises immediate concern for postpartum psychosis, which is a psychiatric emergency. Key warning signs include delusional belief, disorganized thinking, rapid pressure speech, grandiosity, behavioral changes, risk of harm to the infant. Postpartum psychosis typically occurs within the first weeks to months after childbirth. We need to know that the most important priority right now is the infant's safety. Although she denies suicidal or homicidal ideations, her delusional belief that the baby is an alien and must be returned indicates significant risk of harm. Her plan to take the baby camping to leave it on a mountain suggests imminent danger. We need to ensure that the infant is safe immediately, and we need to initiate an urgent psychiatric evaluation and intervention. My immediate actions will include ensuring that the infant is not left alone with the patient, asking the husband to maintain supervision, contacting emergency psychiatric services if necessary. I need to contact Child Protective Services to ensure that the infant is safe. Postpartum psychosis requires immediate inpatient psychiatric hospitalization. If the patient is unwilling to be hospitalized, involuntary commitment may be necessary due to danger to others, specifically the infant. Hospitalization allows diagnostic evaluation, stabilization, medication initiation, the protection of the mother and the infant. The clinical priority again is ensure safety while providing rapid psychiatric treatment and monitoring. We need to do a comprehensive inpatient evaluation to determine the underlying cause and appropriate treatment. Key components of evaluations are a psychiatric assessment. We need to evaluate psychotic symptoms, mood disturbances, and risk of harm self or infant. We need to do a medical screening. We need to rule out medical conditions that may contribute to psychosis. For example, thyroid dysfunction, infections, metabolic disturbances. We need to also evaluate for bipolar disorders. We need to assess for history of mania, hypomania, or mood irritability, as postpartum psychosis is frequently linked to bipolar disorders. We need to evaluate also for sleep deprivation, hormonal change, or substance use that may worsen psychiatric symptoms. Postpartum psychosis is commonly associated with bipolar disorder and requires rapid identification and treatment. Treatments may include antipsychotic medications such as olanzapine or risperidone, mood stabilizers if bipolar disorder is suspected, short-term benzodiazepines for agitation. Medication selection must consider breastfeeding status as well. The following step is family education. Family involvement is essential in managing postpartum psychosis and ensuring patients and infant safety. The husband should be educated about postpartum psychosis. He needs to recognize the warning signs, educate about early symptoms such as paranoia, delusions, confusions, severe mood changes, or sleep disturbances. We need to make sure to emphasize the importance of medication adherence. We need to stress the importance of taking the prescribed medication consistently to maintain stability. We need to monitor for relapse, encourage the husband to observe for returning symptoms, and seek medical help promptly if concerns arise. We also need to emphasize on the importance of sleep stabilization. Emphasize the critical role of adequate sleep, as sleep deprivation can trigger or worsen postpartum psychosis. The clinical goal here is enhance family awareness, improve treatment adherence, and reduce the risk of relapse. After stabilization, treatment should include ongoing psychiatric care, regular follow-up appointments to monitor symptoms and medications effectiveness. It's going to require possible mood stabilizers therapy, psychotherapy. We're going to provide individual therapy to support emotional recovery and coping strategies, family support services, monitoring during future pregnancies. Close psychiatric monitoring is essential as postpartum psychosis has a high risk of recurrence in future pregnancies. The treatment goal here is to promote long-term stability, prevent relapses, and ensure safety for both the mother and the child. This patient demonstrates symptoms consistent with postpartum psychosis, which is a psychiatric emergency with significant risks to both mother and infant. Immediate priorities include ensuring infant safety, arranging emergency psychiatric hospitalizations, and initiating appropriate psychiatric treatment.